Welcome to a new episode of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue, and today I am joined by Dr. Kimberly Pruitt.
Hey there.
And Captain Jesse Murphy. And also, we're going to mix it up a little bit today, and our MC for this podcast, Kyle O'Hay, is also going to be part of the interview process, so kick it over to Kyle to say hello. Thanks for doing this, Kyle.
Hey, you're welcome, Chief. Thank you.
All right. So I want to talk about an interesting case that looks like it had a lot of different facets that we wanted to touch on. Once again, you were on Rescue 12. You were dispatched to a 19 Delta at a hotel room. Kind of let us into what you were thinking while you were en route to this call, some of the things that were going through your head before you got there.
Yeah, I think so. En route to this call, I think in the notes it did say that it was a potential SVT. So we were just kind of going through our SVT treatments and thinking of the drugs and a potential cardioversion, and then also just kind of in general thinking what could also be going on and potential other things that could be causing these problems.
Okay. Perfect. And then you guys arrived on scene. It sounds like the front door was unlocked by a gentleman that was in a wheelchair, and you encountered a very aggressive and large dog. Tell us what you saw.
Yeah, so Engine 12 actually made first contact while we were getting out of the rescue and grabbing all of our stuff. Our pipeman went to the door, and immediately at the door, a dog started lunging after our pipeman. So they immediately slammed the door and told him to put the dog away. The occupants initially didn't want to put the dog away, but we told them that we cannot get in there unless that dog is put away. And meanwhile, we can hear a woman's yelling for us, as well as a man yelling at the dog to try to put him away. So eventually, the dog gets put away in a back hallway. We kind of make entry very cautiously. We find a gentleman in a wheelchair. We're wondering where our patient is, and he tells us it's the female laying on the bed, and we see probably a 45-year-old female laying on the bed, kind of diaphoretic, just laying there, not making eye contact with us. But she is speaking to us, and she's speaking to us clearly. And at that time, she does state that she has SVT regularly. She's had SVT a few times, and that we normally show up, give her medication, and that fixes the problem.
Okay. Great job by everybody slowing down and making sure that the scene was safe. Getting that dog secured, I think, was key. You can't treat anybody unless you guys are safe and secure. So making sure that the dog was put away before you made entry, even though you still had a patient in the back that was yelling for help, I think was an excellent call. So great job doing that. So you talked about the patient themselves being a good historian, at least to be able to tell you what they felt like the situation was going on with them cardiac-wise and what treatments had been worked in the past. Kind of talk us through, because they kind of set you up for kind of tunnel visioning into exactly what you're going to treat. What did you think about that, and what were your next steps?
Exactly. We were worried about that tunnel vision and bypassing potential other dangers and life threats. Kind of the first thing, though, we did focus on cardiac monitoring, put her on the 12 lead immediately, and then getting a base set of vitals. As soon as we saw her in SVT, it was pretty quick that we could see that. We put the pads right on immediately. She was adamant about us not sync cardioverting her, and she was able to speak with us clearly, and so we thought that her mentation was decent enough for us to go the med route as opposed to sync cardioverting her and then also obeying her wishes.
Great. So in terms of her hemodynamic stability, we looked at her, her mental clarity, her judgment. She was able to talk with you. It looked like she was alert and oriented. So we didn't immediately jump to cardioversion, but we also took some vital signs. And what did you guys see in terms of vital signs and how she was presenting?
Yeah, so our initial baseline set of vital signs, I think we had a rate of 184 SVT, pretty, narrow complex, no P waves that we saw. We had a very soft blood pressure. The initial one was 56/37. Pretty much regular O2 sat and regular respiratory rate. Obviously, the only thing that really jumped out at us at that time was that pretty obvious SVT.
Absolutely. And Doc, we talk about hemodynamic stability. We just discussed it, where we talk about their level of response, but then we also think about their blood pressure. Talk to us how you would encounter that issue where someone's talking to you, but they have a BP of 54 systolic.
I really appreciate Kyle's thought process here, and Jeffrey's as well. This patient was alert enough to communicate her wishes. She's had this before. Medicine has worked before. So I like the fact that they recognized the severity of her presentation with her being diaphoretic and a little lethargic and too weak to get off the bed. So they did put the pads on right away, because I'll admit, like, that pressure, the first time I saw that in the chart, I was like, whoa, that patient, could easily classify as unstable. But the fact that she's talking and is also very adamant she does not want to be cardioverted, I think it's worth a try to start with medication, and just always be ready. It's good to anticipate how things are going to go. Try to be one step ahead of your patient, and this is one that could very easily get worse pretty quickly, and these guys were ready for that.
That was great, balancing with, they're right both ways. If they decided to treat the hypotension by introducing electricity, that's one thing. They would have been covered by protocol, but we were having that dialogue with the patient, taking the full 360-degree view, so we know we wanted to wait for that reason. So talk with us, Kyle, quickly on what interventions you decided to do to help treat that patient.
Starting off, at least on my side of things, while all of the rest of our crew was kind of getting her on, our end tidal and some O2 and just kind of getting her stable in those areas. In the basic areas, I just started a line in her left AC with the largest bore IV that we had available, and got prepared pretty much for the adenosine med push with the 20 cc flush.
All right, so you pushed that successfully. Did the patient convert?
Yes, that was what was the interesting part. Was it didn't happen immediately. It took a few seconds, and then she was saying, okay, I'm starting to feel it, and then we saw it actually happen on the monitor whenever she did convert, and she said after that she feels a lot better.
Okay, great. So we did our reassessment of the patient afterwards. It sounds like she became more vitally stable, pressures increased, her level of response, did it change?
She was still kind of lethargic, a little bit out of it, but she was primarily seemed to be concerned with her dog, which was a little bit odd. It seemed like it was a little weird having a pressure as soft. I think we got a second pressure at that time of 92 over 52 right after that. And I guess we just thought that was a little bit weird, that was something that she kept on repeating and saying, and she was a little slow to respond to us.
So she was essentially requesting that the medication be given, she converted, and then that was really it. She didn't want to really go to the hospital for further evaluation. She just wanted the rhythm treated.
Yeah, that's correct. So after she was converted, we started to kind of get her packaged up to transport, and we asking her which hospital she wants to go to, and she was very adamant about not going to a hospital and not being transported. On top of that, she was also stating that she just needed her dog over and over and over again, and that she's not going anywhere without her dog. And then as time progressed, she became more and more agitated.
And we kind of already spoken to the fact that the dog was a little bit aggressive when we first arrived, so we didn't really feel that it was safe to even treat the patient in the home, much less taking that dog with us during transport. It probably would have proven to be a safety issue for not only us, but the Albuquerque ambulance crew and then the accepting physicians as well. So pretty quickly, I would assume the answer was no, we're not going to be able to take the dog.
Yeah, that's correct. And especially because we weren't letting this aggressive dog come back out into the home. She became more agitated. Then the gentleman that was also in the house began approaching the doorway to let the dog out. The dog continued to bark at us and sounded aggressive. And at this time, my lieutenant and the AAS medic called consortium or MSEP and asked about forced transport and what our next course of action would be for this patient.
Okay, so that's a great call to decision making on the patient's behalf is painting that picture, just wanting to discuss with them what what they should expect, what the refusal criteria includes, what the risks are associated with that refusal, and if it's kind of outside of those lines, then we utilize MSEP or we utilize consortium specifically. And I know you didn't make the phone call because you were still tending to the patient, but what was the final direction that was provided by consortium and MSEP?
So they ended up telling us that yes, she absolutely needs to go, especially with that pressure and the information that was given, and that was that my LT had seen was that she was not maintaining appropriately. She has that soft pressure, and that the MSEP did tell us to transport this patient to the hospital.
Okay. And from a medical direction or MSEP standpoint, I know we talked about it briefly, but a lot of the information that we discuss on scene amongst providers is making sure everybody's on the same page. And then once we have an idea of what we want the final disposition to be for that patient, whether it is to allow them to refuse or if we feel like they need to be evaluated further, we want to paint that picture for the physician on the other end of the line. So talk about what your expectations are when that phone rings of what you want to hear from us.
Yeah. So, excellent question. It is nice when everybody's on the same page. There's really usually two key components that I'm listening for when I get this phone call. One is there a true life threat? Do I think that this could play out in a unfortunate direction if we miss something? Does this patient really need to go to the hospital? So if the life threat is present, and it sounds like in this case it was with a very hypotensive patient with a cardiac dysrhythmia, that box was checked pretty easily. The next thing I listen for is capacity. Does this patient truly demonstrate the ability to understand their current situation and the risks and the benefits of refusing? And from my perspective on the phone, this is where I'm really going to defer to the person who is on scene with that patient. And frequently I'll say, I'm not there looking at them, but do you think that they can truly understand what's going on right now? That's much different than A&O times 4. A lot of times people try to start with that, but you can be very confused and not have capacity and still know how many quarters are in a dollar. And so I feel like more along the lines of, can you have a coherent conversation with them, is more of a helpful factor in determining capacity. And once we establish that a patient has a life threat and no capacity to understand the risks, that's a pretty easy decision that we're going to err in making in good faith what we think is a right decision for them, since they can't seem to demonstrate that right now, that we're going to get them to the hospital.
Yeah, absolutely. So after that decision was made or the order was given to execute the transport, the patient obviously still didn't want to, likely because we weren't taking the dog with them. Did it have to get to the point of restraining the patient in order to execute that transport?
Yeah, unfortunately, did. We did work on trying to just communicate with her, tell her the severity of the situation, that we did not feel comfortable leaving her there, and we were not going to be able to take the dog with us because of the aggression, and then the fact that we had the physician's orders to make that transport. So we did end up having to physically restrain her and transport her. During that time, the gentleman in the wheelchair was making his way back to the bathroom door to open the door up for the dog to come out. And the dog was becoming more and more aggressive as well. She was obviously very unhappy, and then also the gentleman became agitated as well.
Was there a secondary phone call made to consortium after the fact, or did it end there?
It ended there. As soon as we put her onto the gurney, and she did fight with us for a second, and then as soon as we put her on the gurney, she made a statement that she's like, I don't feel that very good anymore, and so we're like, okay, this is telling us that you're not stable still, and we got her to kind of calm down while we stayed in the apartment for just a second, just to be like, we're here to actually help you. Let's take a breath, and then we're gonna be going to the hospital. Can we do anything for you? Do you need anything locked up or anything like that? And then she eventually did kind of calm down, but she became a little less, not less responsive, but it seemed like she was a little lethargic at that point.
Okay. So obviously she did need definitive care. So the decision to take her to the hospital, I think, was a good decision overall, although it was difficult. It's a difficult situation to be in, to force somebody to go, especially if you have to involve restraints to get them there. But I'm glad to hear that kind of as the assessment went on, you focused on the good customer service, got the patient to their destination where they needed to be. And unfortunately, they started to feel a little bit worse. So whether they agreed or disagreed initially, I think it was the right call in retrospect. So that was great. I'm going to kick over to our quality assurance captain, Jesse Murphy, and these are calls that you see regularly as far as in terms of symptomatic cardiac rhythms that we treat, both from the slow rhythms to the fast rhythms, right? What are some takeaways that you want to share with the field crews in regards to those call types and how to treat them?
I think that the crew did an excellent job on this. They came in, they did a visual assessment. I think that an experienced provider, within 15 seconds of looking at a patient, interacting with them, they can determine if they're sick or not sick. So they recognized the patient was sick. They appropriately listened to the patient, and then got an ECG, which showed that this patient met all the signs, or the criteria for SVT. It was narrow. There's no identifiable P waves. Rate above 150. The patient is familiar with their history. This is saying SVT all day long, and they confirmed that. They did a great job. They also did a good job of recognizing that we have now a symptomatic patient, and we're right on the cusp between stable and unstable. So I would say that if crews do like Kyle and Joffrey did, they'll do a good job at appropriately getting to the right treatment point, which they did.
And we've seen just anecdotally a lot of cases come through the QA office in regards to fast rhythms that are kind of wide, and then they're getting treated as SVT. If a provider was to come to you and show you a wide complex tachycardia that they treated as SVT, what is your guidance, and what do you kind of point them towards to be able to know that they're identifying the rhythm correctly?
Well, to touch again, like what I said, the classic telltale signs that makes it SVT is, so it has to be regular, right? Has to be greater than rate of 150. There's no P waves. It needs to be narrow. The QRS needs to be less than 0.12 seconds. So if you have a wide QRS, automatically you should say, hey, this is an SVT. Let me look at this further. And that's where we can get consortium involved if we're not sure. We have capability to transport 12 leads to the hospital. They're able to look at those. We have a lot of good technology now that can help us determine what's the best course of action for patients.
That's great. The question comes up regularly. Doc, was there anything else you wanted to cover in terms of
I was just going to say, I recently found 5 reasons to think of a wide complex tachycardia. Number 1's VTAC, and first everyone's mind, could this be VTAC? If it's not, bundle branch blocks can do the same thing, and they can go fast sometimes. So sinus tachycardia in a bundle can look wide. TCA overdose, hyper K, and then of course I'm forgetting the 5th one. I'll think of it in a minute. But anyway, there's other reasons, and if it's wide complex, I'd stay away from adenosine.
And go back to Kyle real quick, because the point we wanted to touch on as well was the dog. And as far as the request to transport that dog, had they been, the dog would have been friendly or more calm, a service dog, those sorts of things. Is that something you've seen in your time in the field, as far as transporting dogs along with the patient in the back of the ambulance, and how is that received?
I'd seen in the past. I'd seen smaller animals that were not aggressive transported with people, and they typically had like a service animal jacket or something on it. And our patient was saying that the dog is a service animal, that we do need to take it. And then just anecdotally, unfortunately, the next day we did have a service animal, quote unquote, maul a child. So it just told us that service animals are not always safe animals.
Mm-hmm. And it's great to note, because obviously we want to be respectful of certified service animals and making sure that we're accompanying them to the hospital if it's necessary. But I think either service animal or not, if they're potentially a safety issue for anybody involved, then we want to make sure that we're maybe having an alternate means to be able to get that animal to the hospital eventually, but not necessarily that they have to ride in the back of the ambulance at the moment. So that's also a great takeaway. Well, this was a good discussion, a lot of moving parts to the call. I think the crews ultimately made a great decision, good outcome for the patient. And then we tackled a lot of different issues in regards to MSEP consults, having the service animals, et cetera. So I think the crews, Medic 12, or Station 12 did a fantastic job making the right decision and making their best judgment on what the patient needed. So I think it was fantastic.
They did a great job, Chief. And so everyone understands why we're talking about this, is that this came as a QA from Lovelace Hospital. The patient was on arrival to the hospital, the patient was alert and oriented, talking in full sentences, decisional, and still restrained. And the hospital thought that maybe that wasn't appropriate. But this is a great example of, as everybody knows, a lot of times what we see and how the patient was, it's because of our interventions that when they get to the hospital, now this is a completely stable patient. And so that might not always, jive with the radio report we get, or even the interventions that we did from the hospital's perspective. So the crew did a great job. I think the learning point from this is that, speaking with Joffrey, he said that this patient ended up being alert and oriented maybe about 10 minutes into the transport. So they're he said that they're close to the big eye at that point. He's talking to this woman who's now completely calm. He's explaining to her what's been done, and he said that she was appreciative and understood the situation and why she was restrained. But we don't often unrestrain a patient. In fact, we almost explicitly never unrestrain a patient. It's usually the unexperienced providers that then want to unrestrain a patient that's now promised to be good after they've gotten to the point that they need to be physically restrained for their safety. So this would be that one rare exception where you have a patient that was restrained for their safety to facilitate a forced order transport, and but this would be a good time to go ahead and take those restraints off on the way to the hospital. And we could armchair quarterback this all day long, but at the end of it, this crew did a fantastic job. You had a patient that was absolutely unstable. They're symptomatic. It was a very dynamic event. It was a danger for the crew. They did a fantastic job taking care of this patient. And when she got to the hospital, she's stable and she's better. So
Nailed it.
Crew did a great job.
Yeah, and that's a great way to close it, and I appreciate you bringing that up, because we talk about regularly in the QA processes. It's not about Monday morning quarterback or what could have, should have been done differently, especially when it comes to the hospitals. I think, although we do a good, thorough assessment, we can only work off what we have in the moment. So if injuries are found later that we may have missed, then we just learning opportunity. We do better the next time, but we don't Monday morning quarterback to say like, hey, you missed this, this, and this. We do our good, thorough assessment. And then in reverse, in this situation, we had a patient who presented poorly. We provided the appropriate treatment, and now that they're doing better, that's a good thing. And the discussion about the removal of the restraints that can happen at the hospital, that's within their purview. But we absolutely did the right thing for this patient with the information and what we had presenting to us. So that's a great point.
Absolutely. And just a final thing to close on is that, I tell everyone that the QA process it's not scary. It's just meant to be educational, and this is a good learning point for everyone in the department, that there are always going to be times to deviate from what we typically do. It needs to be patient-centered, and we need to make a good, thoughtful decision on that. But if you do get a QA, if a hospital, or if you want to enter one, you're not telling on anybody, and it's purely educational for, hey, cool, we went left, maybe we could go right next time, and it usually ends up in everyone recognizing everyone does what they do every day, which is a really good job.
Agreed. It's how we get better. I appreciate that. That's all we have for today. If anybody has an interesting case study they want to submit, please use the SharePoint tab. If you have questions, reach out to the 7-8 or the EMS division. Until then, we'll see you next time. Thanks.